Okay, Dr. Burley, we do have a quorum now.
Okay, excellent. Thank you, Deborah, and welcome everyone. Appreciate you all being here. We'll go ahead and open the meeting for the Medical Advisory Subcommittee. Hopefully you all have an agenda and can follow along. We'll go ahead and start the meeting with call to order and introductions. I will go ahead and start with myself. I'm Dr. Burley. I'm the EMS Medical Director for Monterey County.
Teresa Rios, EMS Agency.
Kimberly Hernandez, EMS Agency.
Deborah Hopgood, EMS Agency.
Steve Brooks, EMS Agency.
Blake Anderson, EMS Agency.
Jesse Allard with EMS.
Derek Orchard, doc at Natividad.
Cassie Caldera, Natividad.
Keith Boyd, alternate for the chiefs of police since Tina is here now.
Thanks, Keith.
Ben Hitchcock, AMR CES.
Nick Greenson, Police Valley Emergency Physician.
Jeff Horner, Air Ambulance Providers.
Good morning, Christy Sobolewski, Chomp Emergency Department.
Sandra Flores, AMR Communications.
Rachel Nealand, AMR CES.
Will Hiller, AMR Operations.
Dave Gillagucci, Santa Cruz, San Benito, EMS.
Justin Reyes, Division Chief of EMS for Monterey County Regional.
Reb Close and Casey Grover, Chomp and Prescribe Safe.
Dean Hearn, California Bridge.
Hey, this is Roxanne from EMS Agency. Not sure if you were able to hear me earlier.
Okay, excellent. Well, thank you, everyone. I think Dr. Hawthorne also joined us as well. And so thank you all for being here. We'll go ahead and move on to an update on EMS agency staff. We have two new staff for the EMS agency who are joining us, and I'll let them talk a little bit about themselves and their background. Jesse Allred. Jesse, would you like to start?
Yeah, thank you, Doc. My name is Jesse Allard. I come to the EMS agency gratefully by the way of Southern California. I'm living up here with my wife and young son. I've had some experience with a few EMS agencies, Napa County, Contra Costa. I recognize Dr. Hearn, for example. So I bring some EMS experience. I'm a longtime paramedic. Happy to be here. I'm really eager to kind of understand and absorb the system and help where possible. So thank you for having me.
Excellent. Thanks, Jesse, and welcome to the agency and to your first medical advisory subcommittee meeting. And then next, we also have Blake Anderson. Blake, would you like to say a few words about yourself?
Yeah, good morning, everyone. Obviously, my name is Blake Anderson. I come from the Sacramento Valley from AMR. We were Tri-County. We worked Sacramento, Yellow, and Placer County. I'm an EMT and have been for a little over 9 years now. This is my first step out of the field, and my background in the field, besides EMT, included field training officer, CISM peer support, and union affairs. I was a chief steward for many years, and I was also part of our strike team. I'm excited to be here in Monterey County and learn your guys' system and meet each and every one of you. Thank you very much.
Excellent. Thanks, Blake, and thanks, Jesse. Welcome again to the EMS agency, and we are very excited to have you and look forward to working with you over the course of the many months and years to come. So welcome. The next item on the agenda is public comment, and any member of the public may address the subcommittee for a period not to exceed 3 minutes on any issue not on the subcommittee's agenda. And Mac will listen to all communications, but may not take any action. So is there any public comment? Okay, hearing none, we'll move on to approval of past MAC meeting minutes. We had a meeting on May 11th for MAC, and you should have the minutes. And so I'd like to entertain a motion for approval of the May 11 MAC meeting minutes.
I moved, Tina Nieto, I moved to approve the minutes.
Noah Hawthorne, second.
Okay, thank you, Chief Nieto and Dr. Hawthorne. So we have a motion and a second. Take a roll call for approval of the May 11 MAC meeting minutes.
Dr. Kalinsky or Dr. Close in her place as an alternate.
Yes, I approve.
Thank you. Dr. Hawthorne.
Aye.
Dr. Orchard.
Aye.
Dr. Greenson.
Aye.
Christy Soboleski.
Aye.
Jesse Caldera.
Aye.
Ben Hitchcock.
Aye.
Jeff Horner.
Aye.
Tina Nieto.
Aye.
And did we have Carrie Campman or Jeremy Hadlin joined by chance? Don't see them. All right, Dr. Burley, that's everyone.
Okay, thank you, Deborah. The next 4 items under approval of past MAC meeting minutes pertain to the AB 361 special meeting minutes from June 8th, July 6th, August 3, and August 30th. And unless there are any objections, I'd like to go ahead and entertain a motion for approval of all 4 of these past MAC meeting minutes.
Jeff Horner, a motion for approval of all 4.
Thank you, Jeff. Do you have a second?
Ben Hitchcock, I'll second.
Thank you, Ben. So we have a motion and a second. Go ahead and take a roll call vote on approval of the MAC meeting minutes for the AB 361 special meetings.
Dr. Close is Dr. Kalinsky's alternate.
Aye.
Dr. Hawthorne.
Aye.
Dr. Orchard.
Aye.
Dr. Greenson.
Aye.
Christy Soboleski.
Aye.
Jesse Caldera.
Aye.
Ben Hitchcock.
Aye.
Jeff Horner.
Aye.
Tina Nieto.
Aye.
That's everyone.
Excellent. Thank you, everyone. The next item on the agenda is correspondence, of which we have no specific correspondence, which brings us on to reports and the EMS agency update with Teresa Rios.
Thank you, Dr. Burley. First, I want to just say that we are so happy to have Jesse and Blake on the EMS team. We are excited about where the agency is going to go with the addition of these 2 team members who are very qualified and so ready to start working with us. As soon as possible, we'll start introducing them to the stakeholders so that everybody knows so they know the team players, and doing some reorganization, shifting of program priorities and responsibilities so that they have their own programs that they can call their own. The EMS agency update staff report included in your packets, as well as a list of items on the agenda, show that the EMS agency continues to be very productive with many projects in the works and others that are starting to line up. There's one item that I would like to highlight, and that is that the EMS agency has been given, CHOMP has agreed to give us access to the STEMI and stroke data. We work with them to provide clarification regarding the EMS agency's role in the oversight of those programs, the STEMI and stroke programs. We addressed all of their questions regarding data collection and reporting, and also related to protection of data. It was a long process, but it has been finalized with a positive outcome. And we always appreciate being able to work with our partners through any of these processes. Questions are asked, we answered. We are happy to answer any questions that anybody may have.
Okay, thank you, Teresa. The next report on the agenda is MOAC activities with Deborah Hopgood.
Dr. Burley, if I could, before we jump into that, we did have a request related to item B, EMS buprenorphine, on the new business calendar to go towards the beginning of the meeting, if it's okay with the committee. Would it be possible to cover that item out of order?
That's fine with me. Any objections to moving the buprenorphine presentation up in the agenda? Okay, perfect. So let's go ahead and get into that item. We have a presentation from Dr. Reb Close with EMS buprenorphine. And Dr. Close, I will go ahead and turn it over to you.
Thank you. And I really appreciate this opportunity, and very grateful for my teammates that are here with me, Dr. Grover, Dr. Hearn, and as well Dr. Giarducci. So just some quick background so we're all on the same page. Obviously, everybody understands very clearly the overdoses that we're dealing with, opiate use disorder, fentanyl. I think that's pretty clear for this team. What I'm grateful to be able to bring today is a potential solution that we can start as this group, and we're actually pulling it forward with Dr. Giarducci's teammates in San Benito and Santa Cruz. So the plan is to take a tri-county approach to treatment. And so just really quickly, we all deal with fentanyl and opiates, and we understand what we're up against, but we have treatment. We actually have something that we can do. And when they studied in emergency departments, either starting patients on treatment with buprenorphine, the medication for opiate use disorder, or the same treatment but no buprenorphine, they had a 50% increase in patients connected to treatment. And for every patient that's in treatment, there's a 70% decreased risk of death. So this is something that this treatment actually saves lives. And so, obviously with our first responders, that's a huge part of what we do. And so I've asked Dr. Hearn to give a presentation on what that looks like at his site and what they're doing in Contra Costa, and how we can, with your approval, how we can move forward on bringing that to the Tri-County area. So I will let Jean take it away. And then we're here to answer questions afterward, anything you need.
Excellent. Thank you so much. Can you hear me okay? Excellent. I really want to thank you for allowing me to speak for just a few minutes. I'm truly honored. Dr. Burley and Dr. Grover and Dr. Close and the EMS agency have heard me speak a little bit about this before, and I'm thankful for the opportunity to bring it to the Medical Advisory Committee. I'm an emergency doc. I work at Highland, but I'm also an EMS doc, and I'm medical director for the AMR operations in Contra Costa, as well as a couple of fire agencies in Alameda County. But in Contra Costa, we started a program that allowed paramedics to start buprenorphine. So I think I have just about 5 minutes worth of slides. So just start this. Right, can you see my main screen? Perfect. So what we're talking about is sort of a combination of EMS and a public health intervention. And this is spurred on by the California Bridge program, which has been sort of illustrative in terms of starting emergency medicine access to buprenorphine for patients with an opiate use disorder. And I think the key is really here that our traditional models of care have sort of failed. We're seeing more and more overdoses every year by both fentanyl and methamphetamine. And we have sort of an urgency to implement some on-demand, wherever these patients are, kind of treatment to get them linked into care. because, and what's true is that the paramedics are really at the scene of this disaster. And so we have a chance to maybe make a difference. And so we started a pilot in Contra Costa. Our aim was, we got together with the public health agency and with the EMS agency and started talking about like ways to optimize services, linking patients from the street into ambulatory sort of based care and talk about some of the outcomes. So I'm going to talk about what we did. In terms of the beginning of this project, we started looking to see what EMS is actually doing out there in the US. And it turns out that while we traditionally think of EMS as just a you call, we haul sort of binary event, there's actually a lot of things that could happen before an overdose call. So for instance, there's screening, there's education, there's first responder naloxone distribution, that sort of thing. Then there's the actual overdose. But then post overdose, there's actually a few other things we could do. We could take patients to a specialized center, we can give a data handoff to public health, and we could potentially do paramedic initiated buprenorphine. And all of these had been done throughout the country in some ways. But we took the 4 things in orange and started them in Contra Costa. So the first thing was we created what we called an overdose receiving center or a bridge site. We only had one of our hospitals in Contra Costa that was really able to be a very effective bridge site. So we called it an overdose receiving center, much on the model of sort of the STEMI or trauma center, in that patients could go to a place that has a substance use navigator and providers who are familiar with buprenorphine, that sort of thing. And surprisingly, we wrote it up and it got published. But a bridge site has basically the same things. You have a substance use navigator, you have providers who are well-versed in buprenorphine, and access to clinics. Second thing we did was a naloxone distribution program based on the Project Friend program in San Francisco. Third thing we did was actually started a paramedic administered buprenorphine program. We were not the first in the country. The first actually was in Camden, New Jersey, but they could only give buprenorphine post Narcan. So we were the second in the country, and we said we didn't care how patients got into withdrawal, but we wanted to give buprenorphine. So it could be post withdrawal from Narcan or pure withdrawal from not having used in a number of days. There's no additional staff needed. It's a pretty simple algorithm, but they do have to access a provider on the phone, and we'll get to that in a second. This is the protocol, and each paramedic has this available to them. They basically go through signs and symptoms of withdrawal, and then there's some exclusion criteria. You can't be pregnant or under 18, or any recent methadone use. Then they do what's called a COWS score. We give them a QR code, and they pull up a COWS score. It's an opioid withdrawal scale, and if the patient is 7 or greater, then they are eligible. At which point, this is the sort of the next part. Then they contact a opioid protocol provider, which in Contra Costa is a group of 7 of us that take call. But San Francisco is using the Poison Control Center, the statewide center, so it's easy access. And then other places are using, like in Alameda County, where we just started, and we're using the base hospital. But the Poison Control Center is a reasonable option. If it's authorized, the paramedics give 16 milligrams under their tongue, and they redose with another 8. Then I think the secret sauce is the fourth item, which was sort of the system integration, where we have our field medics documenting on a PCR. So AMR uses meds. First Watch is a program that does data detection of calls, and First Watch pulls any call that looks like an overdose. And then they send in, if there is an overdose, then they send an email to the substance use navigator as a trigger, and the substance use navigator then logs the contact and tries to reach the patient to get them into clinic. Whether or not they get buprenorphine, if they're an overdose call, then it's flagged by the substance use navigator, and they can look them up. So what's our data so far? We've had about 1,000 potential patients. About 12% have been identified as eligible. About half of them actually got buprenorphine. But we don't really care about the number of patients who got buprenorphine. What we really care about is patients who get hooked into treatment. And with this combination, it turns out that about a third of them, 35 to 40%, actually are in treatment at 30 days, which means a prescription and a follow-up appointment. And that's the bottom line. And so we've published this data so far. People are excited. So like I say, Alameda County is just starting. San Francisco is going to come online soon. But that is the end of my slides. At this point, what's really cool is that there seems to be funding for a new for some new sites. So CDPH likely has funding for it. California Bridge, which is the organization that I also work with, seems to have a little bit of funding as well, although CDPH at the state level has much more. And so this can potentially fund not only the training of medics, but perhaps some administrative time to help purchase the medication, do some tracking for AMR, but also potentially fund some personnel within either the EMS agency or something else to help navigate part of the system. And I'll stop there and see if there are any questions.
Hey, Dr. Hearn, this is Chief Tina Nieto. And I guess Teresa, whoever's running this meeting, is it possible to get a copy of the slideshow?
100%, absolutely.
Thank you.
Dr. Hearn, this is Noah Hawthorne. Do you have any rough estimate in terms of cost on a countywide level in terms of a return on investment, or if the county then became responsible after grant funding ran out for something like this?
Yeah, good question. The cost of what AMR has done in Contra Costa is after the initial training. So we have the training boiled down to about an hour of sort of Zoom videos. So now AMR has just rolled it into their quarterly updates. So it doesn't seem like it's actually changed the training very much. The buprenorphine isn't that expensive, so in the order of a couple $1,000s a year, maybe. So then the question is probably administrative costs. We have a 1 hour meeting every 2 weeks. Where we sort of go through the cases as a steering committee. And so that's sort of the champions. So that's the substance use navigator, the medical directors, and somebody from public health as well. So that's probably the administrative costs, as well as a little bit of admin time to run through these cases. Again, we've never had more than 10 cases a month, which doesn't seem like a ton. But in terms of the overall numbers, it seems like what's really cool is that we haven't had another question people often have is sort of a safety question, and we've had 0 cases of precipitated withdrawal in the 70 patients we've had. And in Camden, they can only give it post Narcan. They have about 180 cases. They've also had 0 cases of precipitated withdrawal. So that's pretty cool. We think it's actually pretty safe. And of course, the treatment for precipitated withdrawal is just more buprenorphine, which is fantastic. So safety seems to be good. And then the question is administrative costs. And so the ongoing costs don't seem to be that great because they're not that many cases. But what's also really cool is it seems as though there's certainly like a burnout and a resilience component to it for the paramedics. It seems like the paramedics who become champions and who've given it more than once seem to be really excited by it and feel like maybe there's something that they're actually doing for these overdose cases, instead of giving them Narcan and having them sign out AMA, or giving them Narcan and transporting them and then not much happens to them in a lot of cases. So what's really cool about buprenorphine, of course, is that it also lasts for 24, 36 hours. And so a patient for the next 36 hours can't die from an overdose because it's such a high affinity. So it feels sort of like a long-acting naloxone, but it makes them feel better. So they're not like miserable from their withdrawal symptoms.
Hey, Dr. Hearn, it's Chief Nieto again. You briefly mentioned possible funding. You talked about the CDPH. There might be some funding there, and you said something else. Is this a one-off, a grant, or is this ongoing, funding?
Yeah, great question. It's at this point, it's probably a one-off grant for a 2-year startup process. So the ramp up is usually like a 3-month ramp up where you train the medics and you train the system. And then it's like it's probably a 2-year grant for $100,000 or a couple $100,000, and then the ongoing costs. And the question is, what the ongoing cost is. In Contra Costa, we just have the 911 transport providers do the buprenorphine, partly because they tend to have a lot more contact with the patient and do the transports. And sometimes the buprenorphine actually happens sort of in the back of the rig as they're heading towards the hospital. So that's how we've modeled it in Contra Costa. San Francisco Fire is doing it with their line medics. And then in Alameda County, it's just Falk, the 911 transporter as well.
And I don't know if Dr. Giudice wants to share anything about his thoughts and information on moving this forward for all 3 counties kind of simultaneously, because obviously we share patients, providers, and services.
Yeah, thanks, Reb. I appreciate that. Hi, good morning, everybody. Thanks for letting me talk. Every time I hear Gene give his presentation, I'm just more and more impressed. And Gene actually has been a champion on this for a number of years at MDAC meetings and so forth. And just anyway, really appreciate his efforts and spurring us into motion. So, you know, I'll just want to add that, you know, sometimes it feels like EMS is just so reactive, and by nature we are. We react to emergencies. We do what we can to help people, but there's, I think, a few opportunities for us to actually be proactive, and I think this is one of those opportunities for a disease that is becoming increasingly more dangerous for a significant proportion of our community. And, you know, every one of these events is otherwise a missed opportunity to make some intervention that might make a real positive impact on people's lives, and frankly, also just reduce the, as Gene said, the burnout and frustration that all of our providers have associated with this. So what I'm working on, I had pushed, there's some I guess some EMSA procedural things that need to happen for a tri-county use of buprenorphine. Right now, it's not under optional scope, which would be, there's a process for applying for optional scope things for paramedics, medications for paramedics, or procedures for paramedics to use. We would have to use what's called a trial study sort of approach, which is what Gene has done in Contra Costa and which San Francisco has just been approved for. So I'm largely just using them as a template. These successful models have a trial study application. I think there's just a few little T's to cross and I's to dot on that. It would be, again, advantageous to have a tri-county approach because, again, we do in many ways sort of share the same patient population. Monterey County, fortunately, is, I think, way ahead of my 2 counties in Santa Cruz and San Benito in terms of treatment follow-up and so forth. We have a lot of work to do in San Benito County to kind of fill some gaps there. We're, I think, doing a little bit better in Santa Cruz County. Obviously, getting people follow-up care is going to be important, expected us. So it's really talking about a kind of whole spectrum of care, including from the 911 call on. What we're proposing is to have an oversight board between the 3 counties that would be comprised of all 3, the medical directors for all 3 counties, which would add up to 2. It'd be John and myself. Also the LEMSA administrators for the 3 counties. We would have AMR CES coordinators. We would have, I have a whole list here, the AMR medical directors, Dr. Close, of course, Casey Grover, of course, Michael Bogey from Hazel Hawkins, the director there. We would have poison control involved. So we would have, I think, a pretty robust oversight board to look at this to make sure that we continue to be safe as we go ahead, and that you know, it continues to provide value to our system. So happy to, I think that's enough from me, but happy to take any questions.
Thanks, Dave. I just want to say that you'll also have the support from California Bridge. I'm happy to be on any steering committee, as well as Vanessa, our program manager. Thank you, everybody. I actually have to jump to another meeting where I'm presenting, but I really appreciate your time, and I'll send the slide deck, and I'm happy to answer other questions offline, and I'll see you at EMCC in a little bit.
Thank you. Any questions I can't answer, I'll take them to Gene and circle back with them. I know we're tight on time and we have a packed agenda. I did want to mention that we do have some funds to help with those initial costs through another grant we have for the substance use response team. So just for initial funding, I know we can get a lot of things started. So I will ask if there's any questions, but otherwise I know we're packed and I don't want to take any more of your time, and I thank you.
Hey, this is Derek Orchard from Natividad, one of the ER physicians. I totally love the idea of getting more support and also a substance abuse navigator in the community. That's key. I came from a hospital in Northern California that was fortunate enough to get one of the early bridge programs. And then now at Natividad, we have a substance abuse navigator as well, and we have naloxone distribution and everything. So I totally see the benefit of that. I don't see the benefit of giving buprenorphine in the field to patients that are just getting transported to the ER. I could see it if the patients, have an overdose, get naloxone, get in withdrawal, and want to sign an AMA and try to give them those resources prior to getting AMA. But the patients that are getting transported to the ER, I'm not seeing the added benefit.
Yeah, I wish Gene were here to share his experience. As you know, a lot of patients after they get naloxone, they do not feel well. I mean, obviously withdrawal is so violent, kind of on how our bodies handle it and how horrible people feel. And so getting them that initial treatment has really made a big difference from what Gene has shared with me with their patients on immediately treating the withdrawal symptoms, immediately showing the patients how buprenorphine will make them feel better and getting them connected to treatment. And of all their patients, the last I heard his numbers, they've only had one leave AMA after receiving buprenorphine. So it seems to facilitate the patient wanting care and treatment, and then getting connected ultimately to care. And the one patient that left AMA ended up following up with their substance use navigator and was one of the long-term patients in care. So I don't know if you want to.
Yeah, I mean, I guess I would just say, this is an option for the paramedics. It does not mean that every patient must receive buprenorphine. Certainly the data would suggest that after naloxone rescue, buprenorphine is very effective for managing opiate withdrawal. So, your point's well taken that, if they're really close to the hospital, what does 10 minutes make a difference? And I think in some ways it's just trying to engage patients however we can. Certainly with 107,000 deaths from overdose this past year in the United States, we're doing something wrong. So I think taking whatever different approach we can to address opiate use disorder is part of what we need to do. But yeah, your point's well taken. And again, I think the way I think of it is it's an option for the medic. And it might just be that they start with post naloxone rescue and then they start to get a sense of when it works better for patients just in withdrawal from abstinence.
Great, that makes sense. Thank you.
Yeah.
Any other questions for Dr. Close or Dr. Grover? Well, thank you all for presenting today. I think it's a very valuable program, and I'm excited about the possibility of moving this forward in concert with Santa Cruz and San Benito. Thanks also, Dr. Galaducci, for being here and speaking on it and with working with us on this initiative. We'll be taking this to EMCC a little later this morning and presenting it there as well. And so this is just kind of informational for this subcommittee at this point, just to let you know what we're thinking and the direction that we'd like to head. And so, think about it some more, bring back some more additional questions, and we'll look forward to continuing to move forward with this initiative. Thank you, Dr. Close, Dr. Grover, Dr. Galaducci, and everything that you do for patients with opioid issues in their lives and who are at risk for potential fatal overdoses. So thank you very much.
Thank you.
Thank you. Thank you so much for this time. I appreciate it. I'll stay on for Dr. Kalinsky, but I want to thank my colleagues and thank you everyone for having us.
Okay, well, we'll go back to our regular agenda, which was under reports. We were about to go into a report on MOAC activities with Deborah Hopgood. So Deborah, I'll let you present that.
There is a written report included in the agenda packet. Since the writing of that report, there has been minimal change in the data related to either COVID or monkeypox. I would just highlight on there that the EMS agency recently participated in the Bronze Pelican exercise at the EOC. We work with agencies throughout the county, including all 4 of the hospitals and long-term care facilities throughout the county. Gave us a really good opportunity to test our resource request processes, run through some evacuation procedures for different facilities, and do some situation status reporting and test communication methods. Otherwise, if there are no questions, that's it for Mohawk.
Thanks, Deborah. Kimberly Hernandez has a report for us for ambulance patient offload times.
Good morning. There is an APOT report in the agenda packet. There were some increases in APOT through the hospitals in June and July to increase the number of the 20 to 60-minute APOT times. It wasn't a large increase, only 1 to 2% of the APOT times increased in that time interval, but that small amount can bump up the 90 percentile and the average. When monitoring this last month, August APOT times, they have been slightly decreasing, and consistently more than 90% of the APOT times continue to be below 20 minutes throughout the county. And we continue to report APOT to all the hospitals weekly. And does anyone have any questions on APOT?
Thank you, Kimberly. So that brings us to old business, and the first item under old business is law enforcement requests related to blood glucose, jail, and medical checks. And Deborah has an update for us on that.
And if I can, Dr. Burley, I'll take items A and B in tandem since the update is the same for both. I'd like to start by thanking Chief Nieto and Chief Boyd for allowing us to participate in the Monterey County Chief Law Enforcement Officers Association meeting this prior week. We were able to take both of these items to that group, share our potential processes and our thoughts on the items, and obtain feedback from all of their members, the chief law enforcement officers from throughout the county. So I felt like it was a really valuable discussion, and we'll be making some modifications to our proposed processes in the form based on the feedback we received at that meeting. And then we'll be reaching out to the jail for some further discussion on the items. So continue to make progress on that. And happy to answer any questions or any feedback on that item, those items.
So like Chief Nieto and I talked that it was kind of, as being the chiefs, it was our responsibility to bring it back to the full context of the board of this committee. There are some significant concerns with that medical clearance document. And I have reservations to engage the jail in that process. In reviewing criteria on that form with medical practitioners, like some of the BGL that's listed on that form, up to 300, that's as I understand it, that's somebody in a little bit of duress. There's some criteria in there on some of those data that doesn't coincide with the idea of somebody having a level at that point being cleared, or having a form that says they're clear. We always, under California law, there's some very specific things in California law that allow jails to reject accepting an inmate to custody, and trauma, medical conditions, things of that nature. And so I think we really need to have some significant discussions once about those forms as a group, so we're clear of it, because frankly, I will not allow my staff to use that form in the sense to present that to the jail in an attempt to get clearance to clear an inmate, because, I think we're putting in a lot of pressure on a paramedic's license. And I'm curious, honestly, if it's within their scope of practice or within legal standards to expose them to that. And I think we're exposing that paramedic and that paramedic agency to considerable liability to say somebody's clear. And if the jail accepted it and within an hour, that person had a medical event that was led to a poor outcome, that could be problematic. That's why we take these individuals to hospitals. And I get the idea of not burdening the hospital system, but at the same time, the hospital system has diagnostic tools available and in essence, more training to make that decision on the ability of somebody to be cleared for incarceration. And so that's my perspective. I just wanted to put it out there. I'm not going to belabor it. I just want to get it on the record so we're clear about that.
So hi, everybody. This is Tina. We did take it to the law chief. So now I'm gonna, that's what Keith believes. But as far as the law chiefs, when it was taken to them, their concerns were that this should not be a, one, you don't ever release to the police because now we're taking the burden, even though you do release, it's on a form. So they're looking at it strictly from a legalese. The second thing, whatever the committee decides to do with this form, you know, it's an EMT form and not a police form. And so they're going to treat it as such if it just becomes one of the forms attached to it. And then they had questions about the jail, about what would the jail do with it, if anything. And we couldn't answer those questions because quite honestly, the sheriff wasn't on the meeting. We couldn't get that answer or question answered. And so that were some of the I guess the concerns that came from other law chiefs regarding the use of the form. And Deborah took a lot of notes, and Deborah, thank you for putting up with us because we're quite hard to wrangle sometimes. And I know Deborah could probably, you know, talk about some more of the concerns because she was taking diligent notes. So.
Yeah, thank you. We were happy to be there and happy to answer questions and get the wealth of feedback on the form. So it will certainly inform us as we move forward. And we'd like to continue to work together with the law chiefs to make the process as good a partnership as we can.
Were there other specific concerns other than the blood glucose that particularly came to light?
One of the primary concerns was related to the section where there's a section within the form that would allow whoever is assuming care of the patient, as it's worded now, it includes a law enforcement officer to essentially sign off and take responsibility for the patient or release the patient. So that was an area of concern that law enforcement officers wouldn't be comfortable signing off on that form. And then there was a lengthy discussion regarding medical clearances in the jail and standards for what they would accept, and some challenges of patients who were transported to hospitals, cleared, and then subsequently had questions raised at the jail, and sort of how that this process, if paramedics were to go out and clear a patient, not necessarily alcohol related, but for other issues, how the jail would respond to that. So hence the need to, before we can move forward with anything, potentially to have a discussion with representatives from the jail and gather their feedback as well as the law enforcement officers' feedback.
And sorry, Chief Boyd here. The one other was the systolic blood pressure standards that are listed on the form, their ratings, and then number 12, medical judgment. You know, you're asking a paramedic to basically say, will they be safe without being seen in the emergency department? So that's it.
Okay, well, thank you. Appreciate your input, and we'll go back within the agency and take a look at all the areas of concern and see if we can continue a dialogue about this and perhaps tweak the process or adjust the process to make it suitable for everyone and with the hopes of moving forward. But thank you. Appreciate your time as always and your input. It's very valuable and much appreciated. So that'll bring us on to the report, Deborah, on the local optional scope of practice for blood and blood product transfusion monitoring.
AMR expressed some questions about the potential rollout of this. So we are meeting with them on Friday to discuss those questions and kind of delve further into this. So more to come on that after we meet with them.
Okay, very good. And then the next item D under the agenda is the 2022 policy protocol review cycle. Steve Brooks has a report for us on that.
Yeah, the report's very simple. Good morning. The 2022 policy cycle completed with implementation of the new and revised policies on July 1 of this year. The rollout actually seemed very smooth and simple. We had probably the smoothest implementation at the July 1 date that we've had in years, probably due to the extensive work that we did, preliminary work that we did to get everything lined up, all the meetings that we held, all the opportunities for comment, I think contributed to a very smooth rollout. So the policies and protocols are in effect, effective July 1. They are on the website, they're on the app, and it went smooth.
Excellent. Thanks, Steve, and appreciate all of your hard work on this, as well as the rest of the team at the EMS agency. Just a huge amount of work coming up with the policy and protocol revisions and all that goes with it. So thank you all, and thanks to everyone who continues to be involved in this process, from public comment to revision of the protocols and discussion of protocols moving forward. I know takes many people to get this job done, and really appreciate your time and attention to this. It's important, and I think it benefits the system and our patients. The next item onto the agenda is item E, which is MAC membership updates, and Deborah has a report for us on that.
We have 2 nominations that are going to EMCC for endorsement today. One is for Rachel Nealon as an alternate for Benjamin Hitchcock, and the second is Christopher Kuzner as an alternate for Jeff Horner. And then we are also currently short 4 members for the committee itself. One from Me Memorial, as a result of a change in ED leadership there. We are reaching out to them to pursue a member to serve in that position. One is a paramedic from an ambulance contractor. We're also working on that position. And then the other 2 are ALS and BLS providers from fire services. MC, FCA reviewed those questions, reviewed that again this week, and will hopefully be providing us a letter with their recommendations in the near future. And that's it.
Thank you, Deborah. Do we need an endorsement on the 2 alternates?
We do not. That'll come from EMCC hopefully later.
Okay, excellent. Thank you. So that moves us on to triage tag days with Steve Brooks.
So with triage tag days, we've been talking about this a bit. It's one of those things that just keeps moving along slowly. What we're looking at is the next 30 days, purchasing triage tags so we have replacements as we do the training with the current stock. We will be distributing a plan of action to include the days assigned for the triage tag training, as well as how we're going to implement and the expectations, as well as what we'll do with the tags when they're done, so that we can track the use and see how the training is doing. And then we'll also be working with the contact people at each of the primary agencies, so we can develop that process in conjunction with them on how to recover the tags and tag pieces, so we can truly do the program review. And that's where it stands at this point. Expect something within the next 30 days.
Okay, thank you, Steve. And the next item is emergency triage, treat, and transport, or ET3 implementation, with Kimberly Hernandez.
After bringing ET3 to the subcommittee, the EMS agency evaluated the feedback and granted AMR approval to implement ET3 as of August 1st. The EMS agency didn't want to miss an opportunity to benefit patients and the EMS system. Ben Hitchcock from AMR will be doing a presentation at EMCC later this morning for anyone who would like to join the meeting to get more information on how the program is going and the data that's being monitored.
Thank you, Kimberly. The next item is 2023 policy protocol review cycle with Steve Brooks.
Okay, 2023 cycle. The cycle is moving along. We are currently in the public comment phase, which ends Friday. So my encouragement is for anybody in this committee, as well as the folks that you represent, please encourage them to review the policies on our website. There's been mass emailings. They're very much available. And we do seek public comment, but it closes Friday. So please, if you haven't reviewed and commented on the policies and protocols, please do so. Once that closes, the EMS agency will be looking at the responses, integrating as appropriate into the policy and protocol revisions, and we'll be moving those through some of our specialty groups and other focus groups, as well as some, I believe we have another kind of open public comment meeting, and which will all focus down towards having these available for review at the January MAC meeting. So that's where we stand at this point. Everything seems to be moving along nicely, though we would certainly enjoy receiving more comments. So that's where it stands.
Excellent. Thank you, Steve. And you also, Steve, have the next item on the agenda, which is the impedance threshold devices.
Right. Also a slow-moving process. As we're looking at the cost benefit and some of the data around it as reported in various literature, and also, you know, the training needs. We're looking at all that, putting that together so we can hopefully move forward, you know, with a good program if it looks like it's something that we really need to do. It does, but we're working on getting everything together so it's successful.
Excellent. Okay, well, thank you all. And that brings us to new business. The first item on the agenda for new business is EMS authority updates to guidance regarding COVID-19 and influenza testing and vaccine administration. And Deborah has a report for us on that.
The EMS authority recently released a memo that permits EMS providers to vaccinate patients 6 months and older, an expansion from the previous age range. We have subsequently updated our protocols due to this being a regulatory change. The changes were put in place immediately, went into effect earlier this week. There is a following chance for public comment, 21-day period that will close on October 13th. That information has been distributed. So if you have any feedback on those or questions regarding those updates to our policies, please send them in prior to October 13th.
Thank you, Deborah. And we already discussed the EMS buprenorphine program, which is item B, which brings us to item C, which is the health data exchange implementation update with Kimberly Hernandez.
The EMS agency executed an amendment to the ESO agreement at the end of June to expand HDE capabilities to all 4 of the Monterey County hospitals. We're working with me and Natividad to implement. However, it is moving a little slower than we originally anticipated. There had been some staff turnover at me, and staff members at Natividad are still discussing implementation with their administration. CHOMP has been hesitant to participate, but we will continue to reach out to CHOMP to address their concerns. SVMH has had HDE implemented since September of 2021, and they have given positive feedback on the HDE implementation at CQI TAC.
Thanks, Kimberly. The next item is MAC bylaws cleanup with Deborah Hopgood.
So policy 1020 related to the EMS committees is one of the policies that was up for review in this review cycle, the 2023 one. As a part of reviewing that, we noticed that the MAC bylaws had previously been approved by the board, but that the policy had somewhat drifted away from the bylaws that had board approval previously. So we noticed that we needed to make some changes to bring those back in line with the policies originally approved by the Board of Supervisors. So as we were reviewing those, we also know that the members are not appointed of MAC are not appointed by the Board of Supervisors, but having the subcommittee fall under the Brown Act has added some extra burdens to the committee, which I think we've all seen illustrated through the AB 361 and the need for meetings every 30 days. So that led us to begin working on a revamp of policy 1020 along with BMAC bylaws and to clean them up some. So what we're looking to do is move the details from the policy to a true bylaws document and bring them back in line with what we had from the board, and then look for any updates that need to be done, including the possibility of moving the subcommittees away from being subject to the Brown Act. So I just wanted to put that out there as an initial discussion as we're beginning into this project and see if there's any comments or feedback from the committee itself, and then we'll provide more details as we move further along into this review.
If I may add, we also surveyed some of the other LEMSAs just to see the structure of those committees and the requirements that they place on those committees. And I personally look at 4 different jurisdictions, and none of them make their subcommittee subject to the Brown Act. In fact, I cannot recall any of the other LEMSAs making the EMCC subject to the Brown Act. You know, as Deborah mentioned, the board has been approving the bylaws. It was around 2015 that a policy was created for EMS advisory committees. And it does create another risk of us, you know, venturing and not having things be consistent. I had never seen bylaws become a policy and have 2 documents. We did consult with county council in that area, and it was thought that it would be cleaner just to have the bylaws as the guiding document for the committees. And as Deborah explained, having EMS advisory committees that is a little bit more general than the way that it is right now.
Okay, thank you, Deborah and Teresa. The next item on the agenda is AB 361 requirements for remote meetings. And Deborah, that's you.
We would just need a consideration from the committee if they are finding that the findings necessary to continue our meeting remotely under AB 361 are still in place. And if they do find so, a motion and a second to continue with the remote meeting processes.
Okay, so we're looking for a motion to continue meeting remotely under AB 361.
This is Tina Nieto. I move to continue meeting remotely under AB 461.
This is Christy Sobleski. I second the motion to continue meeting remotely under AB 361.
Okay, thank you, Chief and Tina, Christy. We'll go ahead and entertain a roll call vote on the motion.
Dr. Close is the alternate for Dr. Kalinsky.
Aye.
Dr. Hawthorne,
Aye.
Dr. Orchard,
Aye.
Dr. Greenson,
Aye.
Christy Soboleski,
Aye.
Cassie Caldera,
Aye.
Ben Hitchcock,
Aye.
Jeff Horner,
Jeff Horner, aye.
and Tina Nieto.
Aye.
That's everyone, Dr. Burley?
Okay, excellent. So the motion carries. We'll continue to meet remotely under AB 361. Incidentally, the next special meeting date is recommended for Wednesday, October 12th at 9:15 a.m. for the next AB 361 compliant special meeting. The next item on the agenda is EMS Quality Improvement Program, specifically CQI tag. And Deborah, you have a report for us on that.
Yes, there is a written report included in the agenda packet as well. The CQI tag is the only group that has held a meeting recently. I would just highlight from there that the EMS agency recently sponsored a training related to human trafficking or the commercial sexual exploitation of children, as the grant said. And we had approximately 40 EMS personnel, hospital personnel, and communication center personnel from throughout the county attend the training. It was offered free of charge to people throughout the county and provided 3 hours of CE credit. Certificates have all been distributed out, and we had very positive feedback from the attendees on the presenters. So.
Thank you, Deborah. That brings us to future agenda items. Are there any items that would like our stakeholders would like to see on the future agenda for our next MAC meeting? Okay, hearing none, we'll move to announcements for good of the order. Any member of the committee may make an announcement or comment. MAC may not discuss or take any action on any item raised during the announcements, except to decide whether to place the matter on a subsequent agenda. So are there any announcements or items for good of the order?
Actually, I had a comment or a question, I'm sorry. In Teresa's staff report, she mentioned that CHOMP would be contributing outcome data, and I was wondering if that data was going to be coming through the ESO system, or was it going to be coming through a third-party platform?
We have access through the American Heart Association, Get with the Guidelines. Steve can probably expand on that.
I'm sorry, I was interrupted by an EMCC issue. What's the question on Get with the Guidelines is?
Oh, that the outcome data.
Oh, outcome data through the Get with the Guidelines registry. We've are working towards reaching an agreement with CHOMP. In principle, we've got an agreement. They just need to get it actually signed. So we will have data for both stroke and STEMI systems through Get with the Guidelines for as long as that data has been entered into that system.
But there's no plan to port the data through ESO so our local providers can glean some meaningful information out of it.
My recollection is that we asked, and I hate to comment, I thought the answer was it doesn't coordinate, but I'd have to go back and look at that to give you a factual answer.
All right, yeah, because that's actually kind of a point of concern where we all use ESO. It's a common platform amongst every provider. I just think it would be in our best interest for meaningful QA/QI if we can find a way to get that information into the platform that we all share.
We agree.
I would add that we did recently complete an agreement that does make that a possibility and expands that possibility to all 4 hospitals. So the agreement is in place, so we would just need to work out the specifics of that and have an agreement from CHOMP to do so.
All right. Thank you.
Are there any other items for good of the order or now general announcements?
I just want to thank everyone for what they do to help our community. I mean, it's just a general announcement. It kind of always goes unknown. EMS sits in the vaccines. They don't get as much credit for what they do, but I do want to thank everyone for what you do in your roles for our community. So thank you.
Thank you, Chief Boyd, and that's appreciated and also reciprocated with law enforcement. We recognize the tremendous service that law enforcement provides to the community, and we really value our relationship with law enforcement. So thank you all as well for everything that you do.
And let me just add, for those who don't know Keith, that's how he gets warm and fuzzy at the end after he's very passionate about an issue. And so thank you, Keith. Air hug.
Excellent. Well, thank you guys. That brings us to the next item on the agenda, which is simply notation of our upcoming meeting dates for the Medical Advisory Subcommittee under AB 361. We'll be meeting on Wednesday, October 12th at 9:15 a.m. And our next regularly scheduled medical advisory subcommittee meeting is scheduled for Wednesday, November 9 at 8:30 a.m. So we'll look forward to seeing you all on those upcoming meetings. And that brings us to adjournment. Thank you all for your participation, and always enjoy our meetings. And we look forward to seeing you at our next meeting, and also seeing many of you at EMCC. So thanks very much. We'll go ahead and adjourn.